And the main purpose of this talk is to cover some of the standard pulse sequences that we use in MR interpretation. And we'll also look at the various joints. We'll look at the normal anatomy and the common injury patterns that occur in these joints, which is going to be important for you to understand to be successful on the test. So we'll talk about the standard pulse sequences that are used with MR imaging, and then we'll go through joint by joint, starting with the lower extremity, and then move into the upper extremity, specifically looking at the normal MR anatomic appearance and the injury patterns that occur. With MR imaging, we have to have a magnet. It can be a high field or a low field magnet, and then a radio frequency coil. These are specific to the body part that you're looking at. So you might have one for the knee or the shoulder or the wrist, and these are radio frequency coils that emit and then receive RF pulses, and this is what we use to develop the image for the MRI. And there's 4 standard pulse sequences that we use with musculoskeletal imaging. These are T1, the T2 weighted sequence, the proton density sequence, and then the gradient echo sequence. And we'll just speak briefly about these, why we use each of these, what they're good for in musculoskeletal imaging, and why we need the specific pulse sequences. So we'll start out with the T1 pulse sequence, and this is typically referred to as the anatomic image. It's a very high resolution image, and it provides excellent soft tissue contrast. When we look at the image, you can tell that it's an MR T1 weighted image if you see that the muscle and water signal are similar in characteristics. So the muscle is intermediate and the joint fluid is intermediate in signal. This is a T1 weighted sequence. We see that calcium, such as the cortex of bone or any soft tissue calcification, is going to be dark. Fibrous tissue, such as a tendon, a meniscus, or a labrum, are going to be dark on T1. And then the fat signal is bright on T1 weighted imaging. And we typically see fat signal in the subcutaneous fat and in the marrow of bone. So if you see bright signal in these areas, you know that you're dealing primarily with a T1 weighted image. The T2 weighted image, on the other hand, we refer to as the pathology image. And really the only difference between the two images is that muscle is intermediate, but the water signal is bright. So when you see bright joint fluid or bright fluid signal within the joint, then you know that we're dealing with a T2 weighted pulse sequence. And these sequences are best for depicting soft tissue abnormalities because of the bright signal that shows up with the water. Once again, the calcium, such as the cortex of bone, is dark. Fibrous tissue like the labrum, the menisci, the tendons are going to be dark on the T2 weighted sequence. And if we did a standard T2 pulse sequence, the marrow and the fat would be bright. But in musculoskeletal imaging, we apply a fat saturation technique to take away all the signal in that typically is generated by the fat. And this makes the water signal more conspicuous so we can see the pathology better. So in T2 weighted imaging in the musculoskeletal system, we're going to see bright fluid in the joint, but the bright signal in the bone and subcutaneous fat is subtracted out of the image. If we look at what the benefit of a T1 weighted sequence is, we can usually see processes that go on in the marrow. So here we see the marrow is bright, and we have a non-displaced, radiographically occult greater tuberosity fracture. We see this low signal intensity line through the greater trochanter or through the greater tuberosity, and this represents a non-displaced fracture. Here we see an area of geographic marrow abnormality within the subchondral region of the humeral head, and this represents avascular necrosis. Again, it's replacing the normal fat signal within the humeral head. If we see signal on a T1 weighted image that's low, equal to or less than muscle, then this is indicative of some type of marrow replacement process. We can see this with lymphoma, metastatic disease, multiple myeloma, or possibly a primary neoplasm. So T1 weighted imaging is very helpful in assessing marrow infiltrative processes. Calcifications show up dark, so we can see calcific tendinitis is a focal globular area of low signal abnormality within the bursa or within the tendon. Fat signal is bright, so this is helpful for evaluating for abnormalities such as fatty infiltration of the muscle. Here we see bright signal within the supraspinatus muscle indicative of fatty replacement or fatty infiltration of the supraspinatus muscle. When dealing with the knee, The meniscus should be dark on all pulse sequences. The T1 weighted image is actually the most sensitive for detecting meniscal tears, and we're looking for a surfacing signal within the meniscus, as we see here, a far peripheral vertical tear of the posterior horn of the medial meniscus. It's excellent for detecting non-displaced fractures about the knee as well. And here's an area of, we have this background of bright signal within the knee or within the distal femur and proximal tibia. Then we have this low signal transverse area in the medial tibial metaphysis representing a stress fracture. So again, these problems that occur in the bone are easily demonstrated on the T1 weighted images. The T2 weighted image, on the other hand, we have this bright signal that's in the joint fluid. So we see that this is a T2 weighted pulse sequence. These sequences are best for detecting any of the soft tissue abnormalities. Here we see a full thickness tear of the rotator cuff with a kind of thickened, edematous, and retracted torn tendon end with fluid present within the subacromiosubdeltoid bursa. Here we see a fluid collection that's located adjacent to the bursa, adjacent to the superior labrum, extending into the suprascapular notch. So we see the posterior superior labrum has fluid signal extending into it, representing a labral tear, and then we see an adjacent paralabral cyst within the suprascapular notch. So again, the T2 weighted pulse sequence, excellent for demonstrating soft tissue abnormalities. It's also very good for demonstrating injuries of the muscle. So here we have fluid signal within the substance of the infraspinatus muscle, demonstrating a grade 2 partial thickness tear with partial retraction and a small intramuscular hematoma. About the knee, we can tell we're dealing with a T2 weighted sequence if we see bright fluid within the joint. And here we see a large fluid collection posteriorly. So this is a Baker's cyst. And again, T2 weighted sequence is most sensitive for detecting fluid and is going to be the best sequence to identify things such as a Baker's cyst. We can see bone contusions rather than bone fractures on the T2 weighted pulse sequence. Once we do the fat saturation technique on the T2 sequence, the bone marrow should be very low signal. And in this particular case, we see a bone contusion in the posterior aspect of the lateral femoral condyle and the posterior aspect of the lateral tibial plateau, representing a pivot shift bone contusion pattern. And here again, we see this bright T2 signal within the joint space adjacent to the patella, indicative of a joint effusion, indicating that this is a T2 weighted pulse sequence. Here we see a parameniscal cyst along the lateral joint line. So we see the small fluid collection lobulated, abutting the peripheral aspect of the lateral meniscus with surfacing horizontal signal consistent with a parameniscal cyst and meniscal tear. The proton density sequence is really an intermediate sequence between the T1 and T2 weighted sequences. It has the best, has really the benefit of both T1 and T2. It's a very high signal to noise image, so it has very high spatial resolution, but it also has the bright signal associated with the water. So we see a high anatomic detail and the pathologic image of high signal within the water. So this is excellent for evaluating things such as cartilage abnormalities. We can see small chondral defects with subchondral marrow edema. We can see disruption, maceration, and tearing of the posterior horn of the medial meniscus in this particular case. So the proton density is kind of an intermediate between the T1 and T2, has the great anatomic detail of a T1, but also shows us the pathology that we typically see in a T2 weighted image. In the shoulder, it's excellent for evaluating the labrum. Here we can see a tear of the anterior inferior glenoid labrum with disruption of the scapular periosteum. We see a small adjacent chondral defect within the anterior inferior quadrant. Finally, the gradient echo sequence. This is considered the high resolution image. We obtain these images in a 3D volume, and then we can get slices as small as 1 millimeter in thickness. So this is great for evaluating the intrinsic ligaments of the wrist or for assessing cartilage, whether it be in the knee or shoulder or the ankle. Also, gradient echo imaging has an artifact that we refer to as blooming artifact, and this is an artifact where if there is calcification within the soft tissues or a foreign body, the area of abnormality blooms or gets bigger at the time of imaging. And so this can be helpful in identifying calcific tendonitis. This is a case where there's a suspected foreign body in the anterior soft tissues along the lateral aspect of the ankle. Here's a proton density image showing a focal area of low signal abnormality. And when we do the gradient echo imaging, we see that this area blooms or gets much larger. So it can be very helpful in identifying foreign bodies within the soft tissues. So that's part of the role of the gradient echo imaging. Now we're going to move on to imaging of the knee. With this, in the knee, we need to be familiar with ACL tears, MCL tears, meniscal tears, chondral abnormalities. Those are some of the most common topics that will show up on the test. It's going to be important to be able to identify a normal appearance of the ACL on all three imaging planes. It's fair game to show the ACL in the coronal or the axial imaging plane. Here we see a sagittal image of a normal ACL. It parallels the roof of the endochondral notch. We can see that the proximal fibers are dark. As it extends more distally, we have intermediate signal striations between the various bundles of the ACL. In the coronal imaging plane, we can clearly see the two bundles, anterior medial and the posterolateral bundle. We see the proximal and distal attachment site. In the axial imaging plane, we primarily use axial imaging to assess the proximal attachment site. Tears at the proximal attachment site are most easily depicted on the axial image. We can see that the normal ACL appearance is a thin band-like structure that's plastered up against the cortex of the inner aspect of the lateral femoral condyle. Here's kind of a mag-up view showing that normal ACL at the proximal attachment site. With the tear of the proximal ACL, we're going to see fluid signal, thickening, and edema at the proximal attachment site. So this is a fair question to just show this axial image and then to ask questions about the follow-up and or treatment of an ACL disruption. In the sagittal imaging plane, the primary signs of disruption are abnormal morphology, so thickening and edema, and just a appearance of just a mass of edematous tissues is a primary sign of disruption. Or if you see disrupted fibers with fluid signal extending through the fibers and inferior drooping distally. An ACL avulsion injury at the distal attachment site, we're going to see a small piece of bone that's avulsed away from the tibia. You can see that the ACL fibers themselves look normal, but the injury here is the cortex at the distal attachment site. They may also show indirect signs of ACL injury and expect you to assume the diagnosis of an ACL for establishing the basis of the appropriate treatment. With the pivot shift bone contusion pattern, we have anterior tibial translation. We get impaction of the femur against the lateral femoral condyle with bone contusions of the lateral femoral condyle and posterior tibia. So they could show this in the sagittal or coronal imaging plane and then ask questions regarding the appropriate treatment or follow-up for ACL injury. Another indirect sign you should be familiar with is deepening of the lateral femoral sulcus. If we see this cortical irregularity and deepening of the lateral femoral sulcus with or without bone contusions, this is again a sign of ACL disruption, an indirect sign, and would be fair game to show this to assume that there's an ACL tear present. The Sagone fracture is another indirect sign. You may show this on a simple radiograph, potentially on CT and or MR imaging. And here we see a small avulsion fracture outlined by fluid signal along the lateral aspect of the proximal tibial plateau. Okay, the most common meniscal tears associated with ACL injury in the acute setting, we most commonly see a vertical tear in the posterior horn of the lateral meniscus. And this just happens to be one of the most commonly missed meniscal tears on MR imaging. So any kind of abnormality we see in the posterior horn lateral meniscus with an ACL injury, we view it with very high suspicion for a tear. The O'Donoghue triad is disruption of the ACL, injury of the medial collateral ligament, and a tear of the posterior horn lateral meniscus. In the sagittal imaging plane, we can see fluid signal extending through the proximal fibers of the ACL, indicative of a disruption. We can see the bone contusions in the lateral compartment of the knee on the coronal images, and then the surfacing signal in the posterior horn lateral meniscus. Okay, you need to be familiar with the normal appearance of the PCL. When the knee is fully extended at imaging, this is a curvilinear structure which is uniform in thickness and uniform in low signal. The most common mechanism of injury is the dashboard injury. This occurs when the knee is flexed and there's tension that's applied to the anterior aspect of the tibia, driving the tibia posteriorly, and then this injures the PCL. We often see bone contusion in the anterior proximal tibia and possibly contusion within the anterior soft tissues. And here we see a frank disruption with fluid signal extending through the mid-substance of the PCL. The more common injury would be a partial thickness tear or a sprain of the PCL. And with this, we'll just see thickening and edema, but the fibers are intact with no frank or gross disruption or discontinuity. Once again, here we see the anterior soft tissue contusion associated with the dashboard mechanism of injury. Now, just like with the ACL injury, we can have a avulsion fracture at either the proximal or distal attachment site. The MRI shows a small avulsion fracture involving the posterior tibia at the distal PCL attachment site. We can see the low signal intensity fracture with adjacent marrow edema. And on the CT, we can see the avulsion fracture at the level of the distal footprint of the PCL. Medial collateral ligament injuries are graded on a 3-point scale, similar to a sprain, partial thickness tear, complete tear. So with grade 1 sprain, we have superficial soft tissue edema tracking just superficial to the MCL. With a partial thickness tear, we have partial disruption, thickening, and edema. And in this particular case, we see a bone contusion in the lateral aspect of the knee, indicating a direct contact with a valgus mechanism of injury, giving you a grade 2 sprain. And then a type 3 or grade 3 injury is a complete disruption where you have complete discontinuity of the fibers. We can see this either proximally or distally with a lax, wavy appearing MCL fiber. Transient dislocation of the patella, a common test question. The imaging appearance is classic. Oftentimes these patients present with a history of a twisting injury. They have a transient dislocation of the patella at the time of the incident, but the patella relocates. They present with medial joint line tenderness and don't really know that they had a dislocation, so the MRI is often the first clue that these patients had a transient dislocation. We're looking for bone contusion within the medial patellar facet and the lateral femoral condyle, which occurs at the time of the impaction injury, at the time of the dislocation. So this bone contusion pattern is typical of a recent transient dislocation of the patella. The surgical injuries we're looking for are osteochondral injuries of the patella. And so here we see a partially detached chondral fragment arising in the lower pole of the patella. We see a large hemarthrosis in the knee. On the coronal imaging plane, we see a detached osteochondral fragment arising along the anterior peripheral aspect of the lateral femoral condyle. So these are surgical lesions, and we need to look at both locations, both the patella and the lateral femoral condyle for osteochondral lesions. Also, we need to assess the integrity of the medial patellofemoral ligament. This is a structure which arises from the superior pole of the patella, then extends along the deep surface of the vastus medialis obliquus muscle, inserts on the adductor tubercle. When we see a patient with clinical signs or imaging signs of patellar dislocation, we assess the integrity of the MPFL. And here we see a large fluid collection or hematoma uplifting and displacing the vastus medialis obliquus muscle. And this is indicative of a full thickness tear of the MPFL at the femoral attachment site. And this is the most common location in the adult patient. In the adolescent patient, it's more common to see this injury at the patellar attachment site. Assessing the patellar tendon should be low signal throughout. It should be uniform thickness. When we start to see thickening and intermediate signal, this is a sign of patellar tendinosis or jumper's knee. Once we see fluid signal into the substance of the tendon, this is indicative of partial thickness tear. They most commonly occur at the proximal attachment site. We might see surrounding soft tissue edema, superficial and deep. And then, of course, a full thickness tear, we see disruption, laxity, and discontinuity of the patellar tendon. The quadriceps tendon, again, should be uniform in thickness and signal. We may see some very thin internal striations associated with the separate bundles of the quadriceps tendon. But once we start to see thickening and edema, as we see in the right-hand image, this is indicative of tendinosis. A partial thickness tear, we'll see partial discontinuity with fluid signal extending into the substance of the tear. And then with a full thickness tear, we see frank discontinuity of the tendon and inferior displacement of the patella. Looking at the menisci are composed of fibrocartilage, so they're low signal in T1 and T2. The T1 and PD imaging is most sensitive for detecting meniscal tears. When we image through the peripheral aspect of the meniscus, we see that the anterior and posterior horn is connected by the body of the meniscus, and this is referred to as a bow tie configuration. As you image more centrally, you see this anterior and posterior triangle appearance. You need to be familiar with the direct imaging signs of meniscal tear. Grade 3 surfacing signal, or anything that goes to the surface of the triangle, is indicative of tear. We can see a horizontal tear, a vertical tear, complex surfacing signal indicative of a complex tear. Another direct sign of meniscal injury is a missing meniscal fragment. So in these images, we're looking through the most peripheral aspect of the lateral meniscus, and we see that the anterior horn and posterior horn does not touch, and this is a missing meniscal fragment, abnormal morphology, and in the absence of any prior surgery is indicative of a lateral meniscal tear. We can also look for the displaced meniscal fragment. So if you see a meniscal fragment in the improper location, this is also a direct sign of meniscal tear. Two of the most common signs we see and often show up on examination is the double PCL sign, and this is specific for the medial meniscus bucket handle tear. Here we see the normal appearance of the PCL, and then you see a second structure just inferior to it that looks like a second PCL, and this is actually imaging through the displaced bucket handle tear. And again, if you see this sign, double PCL in the sagittal imaging plane, this is indicative of a tear of the medial meniscus. If you have a tear of the lateral meniscus, the most common sign we see is referred to as the double anterior horn sign. You have a diminutive or absent posterior horn. It flips centrally and anteriorly into the compartment, and it gives you the appearance of two anterior horns and the lack of a posterior horn. And this is the typical appearance for the lateral meniscal bucket handle tear. A discoid meniscus just simply refers to a meniscus that covers the entire weight-bearing surface. No matter how far through centrally you go in the sagittal imaging plane, you still see the anterior and posterior horns touch, and this discoid meniscus has an increased risk for meniscal tear. Don't forget to assess for perimeniscal cysts. Fluid collections adjacent to a meniscal tear are indicative of a perimeniscal cyst associated with that and may alter the treatment algorithm. So here we see bright tissue fluid signal adjacent to the meniscal tear. OCD lesions, we have a 4-point grading system in MRI. Number one is just an intact overlying surface with subchondral marrow edema, and this is a stable lesion. A type 2 lesion, as we see in this picture, is a lesion with partial disruption of the overlying cortex, but the stable is still fragment, or the fragment is still stable anatomically. With a type 3, we have an unstable fragment in situ. Often this is demonstrated as fluid signal surrounding the fragment. You may have adjacent marrow edema and cystic change. And then a type 4 lesion is one in which the fragment is not only unstable, but has been displaced out of the original site. Okay, moving on to imaging of the hip and pelvis. Avascular necrosis is a common imaging appearance that shows up on the examination. And this has a very classic finding. What we see is a geographic area of subchondral marrow abnormality within the humeral head. And then we have this double line sign, which is a bright linear area of signal which parallels a low signal intensity line. And this is the healing interface of granulation tissue that occurs at the interface of the dead and live bone. It's referred to as a double line sign, and it's very specific for AVN. You can see this in the humeral head, you can see it in the femoral head, you can see it in the talus, in the calcaneus. If you see this double line sign in a geographic area of marrow abnormality, this is indicative of avascular necrosis. In the advanced case, we may see cortical collapse or secondary osteoarthritis, and in imaging of the hip, we often see this bilateral. Okay, another common imaging appearance is that of a stress fracture. We can see this on radiographs, but it's often a late finding on radiographs. It's a low signal intensity line, which is runs perpendicular to the primary trabeculae. However, in MR imaging, we see the findings very early in the process. So again, we see a low signal intensity line, typically running perpendicular to the primary trabeculae of the given bone, and then adjacent marrow edema. So we can see this along the medial or lateral aspect of the femoral neck. Avulsion injuries of the pelvis, need to be familiar with the normal attachment sites about the pelvis. We have the rectus abdominis aponeurosis, which attaches to the pubic rami centrally, the hamstring tendons, ischial tuberosity. Then if we start along the superior margin of the pelvis, we have the abdominal musculature that attaches to the pelvic rim, sartorius, anterior superior inferior, or anterior superior iliac spine, rectus femoris, anterior inferior iliac spine, iliopsoas to the lesser trochanter, and the gluteus medius to the greater trochanter. Typically, these avulsion injuries occur in the young athletic population that are still skeletally immature before the apophysis growth plate closes. Oftentimes, these can be diagnosed with radiographic imaging when we see these avulsion fractures. Here's one of the anterior superior iliac spine involved in the sartorius origin. Here's a avulsion fracture shown in a radiograph of the anterior inferior iliac spine, the rectus femoris attachment site. But sometimes the radiographs are non-diagnostic or don't demonstrate the abnormality, so we can move on to MR imaging. And what we see is subtle displacement of the apophysis, either the cartilage or the or ossification within the apophysis. And then we see fluid signal separating the apophysis from the native bone. So this is the classic appearance that we would see with a non-displaced rectus femoris avulsion injury. With ischial tuberosity, we often see a large piece of bone that comes with the tendon in the skeletally immature. Here we see a nice example of radiographs and MR imaging showing a large piece of the cortical bone, which is displaced with fluid signal interposed between the donor site and the large fragment. And when these start to heal, they can mimic neoplasm, so you want to remember that as a key. Now, this is a common imaging appearance that we see in adolescent soccer players, particularly boys who are running. We see this bilateral ischial tuberosity apophysitis or marrow edema. The radiographs will be normal, and these patients will present with posterior pain. With regard to muscle injury, we use a grade 3 or a 3-point grading system. A grade 1 is just a strain where we see feathery intramuscular edema, but there's no loss of the normal integrity of the muscle, and no disruption of the muscle. A grade 2 is a partial thickness tear where there's partial disruption of the muscle or the musculotendinous junction, oftentimes with a hematoma. And then a full thickness tear is where we have complete discontinuity, disruption and retraction of the muscle and or tendon, often associated with a large intramuscular hematoma. Finally, these hip pointer lesions are lesions that occur at the iliac crest, most often runners or sprinters, but we can also see them in contact sports such as football, and we can see disruption and avulsion and displacement of the growth plate of the iliac crest, both on MR and CT imaging, with the associated soft tissue edema on MR. Beware of the avulsion fracture of the lesser tuberosity. This is a patient who sustained a fall, presented in the ER with hip pain. When we did the radiograph, we saw that there was an avulsion injury and cortical disruption through the lesser trochanter, and these fractures almost always pathologic in nature, so we followed this up with an MRI, and this was a metastatic adenocarcinoma from the bowel with the initial presentation. So avulsion fractures in these locations, in the adult patient, you need to be aware of possible pathologic fracture. Femoral acetabular impingement syndrome is a hot topic. You should be aware of the normal imaging appearance. We often have this lack of the normal femoral head-neck offset, a cam bump, as we see in the radiograph. On MR imaging, we can see subchondral cystic change or subcortical cystic change at the level of the bump, and then we see low-grade chondral changes and a tear of the acetabulum. The pincer type usually occurs in association with acetabular abnormalities, usually in older patient population, older females. We see marginal spurring and associated with acetabular tear and changes of synovitis in the right hip. Moving on to the ankle, you should be aware of the normal appearance of the Achilles tendon, both in the axial and the sagittal imaging plane. In the sagittal imaging plane, we see that it's a uniform thickness and uniform low signal. When we look in the axial plane, we can see that the normal Achilles tendon should always be flat and or concave along its anterior margin. Once we start to get tendinosis, we see that the anterior margin of the Achilles tendon becomes rounded or convex. So this appearance that they show you an axial image through the ankle, and you see an anterior convex margin of the Achilles tendon. This is indicative of marked Achilles tendinosis. In the sagittal plane, we can see thickening in the watershed zone and intermediate signal within the substance of the tendon. Here's a partial thickness tear at the distal attachment site. There's thickening, abnormal edema, and fluid signal extending into the substance of the Achilles tendon distally. And then a full thickness tear is one in which we have a complete disruption, fluid signal traversing the torn tendon fibers and retraction proximally. If we're assessing the tendons at the level of the ankle, we often use the axial imaging plane, and you need to be able to identify which tendon is abnormal. In the medial compartment, we use the mnemonic Tom, Dick, and Harry, posterior tibialis tendon, then the flexor digitorum longus, and then the flexor hallucis longus tendon. And then we have, of course, the Achilles tendon posteriorly, the extensor tendons in the anterior compartment, and the peroneal tendons noted laterally. Here we see an area of the posterior tibialis tendon which is markedly thickened. We see a longitudinal split within the substance of the tendon. There's surrounding soft tissue changes. We see tenosynovitis of the posterior tibialis tendon sheath, and these findings are indicative of a posterior tibialis tendon dysfunction. With regard to the peroneal tendons, in addition to tendinosis, there's a few abnormalities that are somewhat specific for the peroneal tendons. We can see a longitudinal split of the peroneal brevis tendon. So if you look along the posterior margin of the fibula and you see 3 tendon slips rather than 2, this is often associated with a split of the peroneal brevis tendon. Here we see associated tenosynovitis and fluid within the tendon sheath. We also get disruption of the superior peroneal retinaculum and associated with peroneal tendon subluxation. So here we see partial tearing and stripping of the superior peroneal retinaculum and lateral subluxation of the peroneal longus tendon, and then a longitudinal split of the adjacent peroneal brevis tendon. Talar dome lesions are graded similar to the lesions that we see in the knee. We can see this on radiographs, CT, or MR imaging. And again, type 1 is just marrow edema with an overlying intact cortex and cartilage and is a stable lesion. Type 2 is partially disrupted overlying cortex. Type 3 is complete separation with either contrast or fluid surrounding the fragment. And a type 4 OCD is that of a displaced fragment. Okay, tarsal coalition is also a hot topic item. You need to be able to identify the appearance of tarsal coalition. If you look at the normal talar navicular joint, you see that the cortex is linear and low signal and very smooth. But if you look at the cortex in the middle facet of the subtalar joint, you see that it's undulating and irregular. And on the T2 weighted sequence, we see adjacent edema in the bone, indicating stress-related changes across the joint space. So this is an abnormal fibrous coalition, middle facet subtalar joint associated with reactive marrow edema. This is a tarsal coalition of the tarsonavicular bone with the cuboid. And again, you see this undulating, irregular cortex, abnormal cartilage, and then subchondral marrow edema associated with the abnormal stresses across the joint. We can also see this on CT, where we see this irregular undulating cortex with subchondral cystic change and sclerosis on either side of the fibrous coalition. Okay, now we're moving on to the upper extremity, and we're going to deal with shoulder imaging, another area that you're likely to see several questions dealing with MRI. We need to understand the normal imaging appearance of the rotator cuff complex. The rotator cuff, the musculotendinous junction, typically sits in the 12 o'clock position when we're looking at the MRI in the coronal imaging plane. And then as you move peripherally, as the tendon comes over to insert into bone, it should just be a uniform thickness, uniform low signal, which extends right down and then attaches to the uniformly black cortical line. So this is the normal appearance of the cuff. Once we start to see thickening and edema, bursal or articular site of fraying, this is indicative of cuff tendinosis. We may see fluid in the overlying subacromial subdeltoid bursa, as we see in this case, and we may see signs of impingement with inferior spurring of the AC joint or inferior acromial spurring. Calcifications in the region of the cuff or the bursa can be identified on radiographs. On CT imaging, we're looking for globular areas of low signal abnormality that are present within the bursa or within the substance of the cuff itself. Remember that the gradient echo imaging typically causes this blooming artifact where the calcification appears larger than it is in real life, and this can help detect the presence of calcification either within the bursa or within the substance of the cuff. Now, tears of the cuff are identified when we see fluid signal in the expected location of the cuff, And in this particular case, we see a partial thickness tear at the anterior footprint. This tear appears to be primarily interstitial, but it's high grade in nature. You can see that the bursal and the articular sided fibers are intact, and there's no retraction. This is a partial thickness interstitial tear of the supraspinatus tendon at the anterior attachment site. This is the classic imaging appearance that you would see for a full thickness tear of the rotator cuff. We see there's discontinuity of the cuff. We see bright fluid signal on this T2 weighted image extending through the substance of the cuff. We see fluid within the bursa. We see a slightly high riding humeral head and some subcortical and thesopathic marrow edema within the greater tuberosity. So this is the classic imaging appearance for a full thickness tear of the supraspinatus and or infraspinatus tendons, best depicted in the coronal imaging plane using T2 weighted sequencing. Imaging of the subscapularis tendon is best done in the axial imaging plane. We can see that the musculotendinous junction is along the anterior margin of the glenoid, and then the subscapularis tendon comes across with the deep fibers inserting onto the lesser tuberosity. We have the more superficial fibers coming across to insert onto the greater tuberosity, and that forms this fibroosseous tunnel that holds the biceps tendon or the bicipital groove. With the tear of the subscap, you'll see full thickness defect, retraction, fluid signal in the expected location. If we look in the bicipital groove, we see that it's empty. There's no normal tendon, long head biceps tendon within the bicipital groove. And we look into the joint space and we see that there's medial dislocation of the long head biceps tendon associated with disruption of the subscapularis tendon, the bicipital sling, and the transverse humeral ligament. So this is a common complex that we see most often depicted in the axial imaging plane. The glenoid labrum is best detected, or if we're evaluating the anterior posterior labrum, it's best detected and described using the axial pulse sequences. The labrum, like the meniscus in the knee, is low signal intensity on all pulse sequences. They should be these triangular structures that attach along the anterior and posterior aspect of the osseous glenoid. We can see the adjacent hyaline cartilage was intermediate in signal, and then you see fluid within the joint. So these things are nicely outlined by the fluid in the joint, and they're triangular low signal intensity structures. Tears of the anterior or posterior labrum are best depicted in the axial imaging plane. Here we see a tear of the anterior labrum with the labral fragment torn, displaced. We have disruption of the medial scapular periosteum and low-grade chondral surface irregularity adjacent to the anterior Bankart lesion. MRI can also show an osseous Bankart component. So in this case, we see not only a tear of the labrum, but we see disruption of the anterior inferior glenoid cortex. We can see this fragment is irregular and displaced, and CT imaging can be very helpful in further defining the appearance of the osseous Bankart. Anytime we have more than a loss of about 30% of the bone stock along the anterior inferior margin, this is referred to as the inverted pear appearance. We can see it on this 3D image. And the CT is very helpful for not only detecting the size of the Bankart lesion, but seeing the dislocation or the displacement of the fragment, and to determine if it's a comminuted or a single fracture fragment. This inverted pear appearance corresponds nicely with the arthroscopic image of the inverted pear. The Hill-Sachs lesion is the lesion that occurs along the posterolateral aspect of the humeral head. It's an impaction type injury that occurs secondary to anterior dislocation, with the humeral head impacting against the anterior inferior osseous glenoid rim. Now, if we look at the normal humeral head on MR imaging, the top three images should be perfectly round. So when we see this appearance of humeral head that's perfectly round, that's the normal MR appearance. After dislocation, then you get this impaction type injury, you get flattening or concavity along the posterolateral aspect of the humeral head. In the acute setting, you can see marrow edema, as we see in this particular case, and this represents a Hill-Sachs lesion and indicates a recent or a prior anterior subluxation event. This can also be shown on CT imaging. So once again, if you're looking through the top couple images of the humeral head, it should be a round structure. If you see flattening or concavity, this indicates an previous anterior subluxation event. The superior labrum, like the anterior and posterior, is again composed of fibrocartilage. It's low signal on all pulse sequences, and it's this triangular structure that extends off the superior aspect of the osseous glenoid. You can see the adjacent intermediate signal hyaline cartilage and fluid within the joint outlining the superior labrum. A SLAP lesion, we see abnormal contour or abnormal signal extending into the substance of the triangle. So in this particular case, we see fluid signal extending up into the substance of the triangle. We see this little flap fragment arising from the free edge of the superior glenoid labrum. Now, the middle glenohumeral ligament is a structure that shows up occasionally on this examination. You need to know the normal anatomic appearance of this and not mistake it for some other pathology. The middle glenohumeral ligament arises along the anterior superior glenoid margin. It courses obliquely along the anterior aspect of the glenohumeral joint and represents a thickening of the capsule. On axial imaging, it looks like this band-like structure, which is sitting deep to the subscapularis tendon and superficial to the anterior glenoid labrum. You don't want to mistake this for an avulsed labral fragment or a split tear of the subscapularis tendon. This is a normal anatomic structure, almost invariably seen on MR imaging in the axial plane. The Buford complex is composed of a thickened cord-like middle glenohumeral ligament, which we see situated just deep to the subscapularis tendon in this axial view. We see that there's an absent or diminutive anterior superior labrum, and this composes the Buford complex, a thickened middle glenohumeral ligament, absent anterior inferior labrum. And again, you don't want to mistake this for an avulsion of the anterior inferior glenoid labrum or labral tear. This is a normal anatomic variation. Okay, the Hagel lesion describes, this is an acronym for humeral avulsion of the glenohumeral ligament. The normal anterior band of the inferior glenohumeral ligament is this thin structure which extends from the inferior aspect of the glenoid over to the humeral neck. Normally, it should be a continuous band-like structure. The middle image here shows a disruption at the humeral attachment site. We can see a complete avulsion of the anterior band of the inferior glenohumeral ligament. We see edema in the surrounding soft tissues, and we see fluid leaking through the defect into the adjacent soft tissues. Okay, paralabral cysts in the shoulder are analogous to the parameniscal cysts in the knee. Here we see bright signal abnormality extending into the substance of the superior labrum, diagnostic of a SLAP lesion. And then we see this lobulated bright T2 signal structure extending along the superior aspect of the glenoid into the suprascapular notch. If we look one more image posteriorly, we see that there's diffuse soft tissue edema within the supraspinatus and infraspinatus muscles. And this represents a suprascapular nerve entrapment with neurogenic edema within the supraspinatus and infraspinatus muscles, secondary to the entrapment of the nerve caused by this paralabral cyst. This is an acute case of denervation muscle edema. In the more chronic cases, we'll see fatty atrophy rather than the edema. A throwing injury is another classic injury pattern that you should be familiar with. In these overhead athletes, usually adolescent or young adults, we see abnormal changes of the posterior aspect of the rotator cuff. We can see tendinosis. We can see partial thickness tearing along the undersurface. Then we see the subchondral cyst in the posterior aspect of the humeral head, and then a tear of the posterior labrum. And this injury pattern is specific for internal impingement in throwing or overhead athletes. In the adolescent population, we need to also be aware of the epiphyseal plate stress-related injury. The radiograph just shows a frank fracture through the growth plate in an overhead athlete, whereas most of these come to our attention before they have an acute fracture. And on MR imaging, we see widening of the growth plate peripherally, and we see increased T2 signal within and adjacent to the growth plate and some periostitis. And in this particular 14-year-old overhead athlete, we also see tendinosis and scuffing on the undersurface of the cuff. So this patient has not only signs of internal impingement, but early stress-related changes of the proximal humeral growth plate. A common weightlifting injury is a posterior labral tear. Here we can see the axial image through the shoulder shows that the musculature is very well developed, as you would expect with a high-end weightlifter. And then we see this fluid signal with detachment and displacement of the posterior inferior glenoid labrum, representing a posterior labral tear. Another classic injury in weightlifters is osteolysis of the distal clavicle. This can be either secondary to an acute traumatic event or secondary to repetitive stress, as occurs with weightlifters. And the radiographic appearance is that of loss of the normal cortical line, subchondral lucency, and cystic change, whereas in MR imaging, we can see this much earlier. We see intense marrow edema within the distal clavicle. There's usually an associated small AC joint effusion, pericapsular edema, and periostitis along the distal aspect of the clavicle. Okay, moving on to elbow imaging. The most common things you'll see if you're shown elbow imaging with MR is either going to be a biceps or triceps injury. They may show a medial or lateral epicondylitis. Often ulnar collateral ligament is a common abnormality that's shown, or some type of osteochondral injury or intra-articular bodies. So let's start out and look at the normal anatomy of the biceps. The biceps tendon, the musculotendinous junction, is up at the lower aspect of the upper arm. Then the biceps tendon typically extends 7 or 8 centimeters and then comes down and inserts onto the radial tuberosity. So that if you want to look at the entire tendon and its length, it's best visualized in the sagittal imaging plane. However, it's the axial image which is best for detecting any kind of injury or for grading the injury at the distal attachment site. So this is the normal appearance of the distal attachment of the biceps tendon to the radial tuberosity seen in the axial imaging plane. In this particular case, we had someone with an axial load to a flexed elbow, felt a popping sensation with anterior elbow pain and loss of strength. And we see on the sagittal images that there's thickening of the biceps tendon. We see disruption and retraction. We see soft tissue edema tracking adjacent to the distal biceps tendon. But it's really the axial imaging plane where we can see the distal attachment site and confirm for certainty that it's a full thickness tear versus a partial thickness tear. And in the axial imaging plane, we see a fluid collection sitting right in the expected location of the distal biceps tendon. So we always insist that our technologists get the axial images all the way down through the radial tuberosity anytime there's a suspected biceps tendon tear, because this is the key image for detecting full thickness tear versus partial thickness tear or distal insertional tendinosis. With regard to the triceps tendon, again, this is best depicted. The triceps tendon is best depicted in the sagittal imaging plane. We see that it's a multiseptate tendon coming down, inserting into the olecranon process posteriorly. At the time of injury, occasionally we'll see a small cortical fleck on radiographs associated with a complete avulsion or tear, but it's the MR image that shows the soft tissue abnormality. And here we see a full thickness tear disruption with approximately 3 to 4 centimeters of proximal retraction of the torn triceps tendon. We see the extensive adjacent soft tissue edema and swelling posteriorly, and occasionally we'll see a small cortical avulsion fracture fragment associated with the distal triceps avulsion injury. Okay, medial epicondylitis is common flexor tendinosis and or tear. If you look on the lateral side, you can see the normal common extensor tendon, which is a low signal band-like structure arising from the lateral epicondyle. On the medial side, we see that there's a high signal within the substance of the common flexor tendon, and this is indicative of tendinosis. Okay, ulnar collateral ligament injury, a common injury in throwers and pitchers. The ulnar collateral ligament is composed of an anterior and posterior band. It's the anterior band which is most important, and this is the one that shows up best on MR imaging. It's this thin band-like structure which runs from the medial epicondyle down to insert onto the sublime tubercle of the proximal ulna. So this would be a continuous low signal band extending from the medial epicondyle to the sublime tubercle. With disruption or tear in a thrower, often these patients are throwing. They experience a sudden onset pain with a pop sensation, and then they lose the ability to throw or to have any kind of velocity or accuracy on their throw. With MR imaging, we can see a complete disruption with extensive adjacent edema through the proximal fibers of the ulnar collateral ligament and some overlying strain and edema within the common flexor muscle group. So this is a full thickness tear, often occurs within the proximal to mid substance of the ligament. The partial thickness tears are more likely to occur at the distal attachment site, and this is referred to as the T sign and represents a partial thickness tear of the deep fibers of the distal ulnar collateral ligament. If you look on the image on the left, you can see that the distal attachment site, there's never fluid that normally extends between the distal attachment of the ulnar collateral ligament and the sublime tubercle. If we back up here two images, we can see the distal attachment site. There's never fluid extending between the distal attachment site of the UCL and the sublime tubercle. On this particular image where you see this fluid tracking deep, this represents a partial thickness tear, and this is an incompetent ulnar collateral ligament that would need to be reconstructed. So this is referred to as the T sign of the partial thickness tear. Okay, we can also see osteochondral injuries in certain athletes, gymnasts, where the arm becomes the weight-bearing extremity. We can have an impaction type injury between the capitellum and the radial head. And here we see a full thickness osteochondral lesion, which is detached and separated, and we see the loose body within the posterior aspect of the elbow joint. And here's a professional baseball player that had radiocapitellar impaction syndrome. There's no disruption of the overlying cortex, but he's got subchondral sclerosis and marrow edema within the capitellum, indicating an impaction type injury. Evaluation of the lateral epicondyle. Once again, if you look on the medial side, you'll see that nice thin band, which represents the common flexor tendon. On the lateral side where the arrow is, we see fluid signal within the substance of the common extensor tendon, and this represents a high-grade partial thickness tear of the common extensor tendon, representing MRI findings of lateral epicondylitis. We can see some slight thickening, but no tear of the adjacent radial collateral ligament or lateral ulnar collateral ligament. Okay, finally, we move on to imaging of the hand and wrist. Tenosynovitis and tendinopathy is a common reason for imaging through the hand and wrist. And in this particular case, we can see that there's fluid signal surrounding nearly every tendon sheath in the extensor side of the wrist. And this fluid within and adjacent to the tendons represents tenosynovitis. The extensor carpi ulnaris tendon is thickened. We see intermediate signal within the substance, and that represents tendinosis. So it's the axial imaging plane which is best for evaluation of the tendons in the region of the hand and wrist. This is a case of de Quervain syndrome where the patient presented with a painful mass along the radial aspect of the wrist. We see a large, bulging, fluid-filled first extensor compartment. We see thickening and partial thickness longitudinal tearing involving the extensor pollicis brevis and abductor pollicis longus, indicating signs of de Quervain syndrome. We can evaluate the intrinsic ligaments of the wrist. This is an MR arthrogram where we've injected contrast into the radiocarpal compartment, and we see a complete disruption of the scapholunate ligament at the scaphoid attachment site. We see contrast spilling through this defect into the midcarpal compartment. We see widening of the scapholunate interval. If you compare this with the lunotraquetral interval, you can see that it's widened, and these are signs of a complete full thickness tear of the scapholunate ligament. Ulnar impaction syndrome is an impingement syndrome that occurs when you have either a prominent ulnar head or positive ulnar variance. You can see on the radiographs we have the subchondral cystic change and sclerosis in the lunate. On MR imaging, we see a full thickness tear of the central articular disc of the TFCC with fluid extending through the defect. We see the arthrosis and the chondral fraying of the adjacent lunate with subchondral cystic change and marrow edema, typical of ulnar lunate abutment syndrome. MRI is excellent for depicting AVN in the wrist, and here we have a case of AVN of the lunate. In the earliest changes of AVN, the radiographs will be normal, but on MRI we'll see a marrow edema within the necrotic piece of bone. Here we see diffuse marrow edema throughout the lunate with no history of trauma. This is indicative of early changes of avascular necrosis or Kienbach's disease. In the more advanced cases, we'll see fragmentation, collapse, and even fracture through the body of the lunate. Evaluation of scaphoid fracture complications. MR is excellent for this. We can look for changes of either avascular necrosis and or signs of malunion or non-union at the fracture site. With the radiographic imaging, we usually see sclerosis in the area of AVN. If you remember, the blood supply is a retrograde blood supply, so the vessels come in distally and then feed back into the proximal pole. With AVN, we'll see low signal abnormality within the proximal pole on T1 and T2 weighted imaging. Signs of fracture non-union is when we see no evidence of bridging trabeculae. Oftentimes we'll see sclerotic margins on either side of the fracture with adjacent cystic change, and these are MR imaging findings consistent with fracture non-union or fracture malunion. If you look at the radioscapuloid joint near the radial styloid, you'll see that there's early secondary osteoarthritis developing with chondral loss and marginal spurring. The Stenner's lesion is a tear of the ulnar collateral ligament of the first metacarpophalangeal joint. We can see that in this particular MR case, the ligament is torn at the distal attachment site. It's retracted proximal to the adductor aponeurosis with entrapment of the fracture fragment and the torn ligament, and this is indicative of a Stenner's lesion. So now we're just going to go through a couple questions just to show you some examples of what you might face as far as MR imaging examples. And so this is question number 1. A 15-year-old female complaint of medial joint line pain of the right knee, swelling and locking after a twisting type injury of the knee while playing volleyball. The radiographs demonstrate a large joint effusion but are otherwise unremarkable. MR images are shown below. What is the most likely diagnosis? So we have an axial T2 weighted image with fluid in the joint. We have a sagittal PD image with fluid in the joint. The potential answers are A, is this an ACL tear with a displaced bucket handle tear of the medial meniscus? B, medial femoral condyle OCD with a displaced osteochondral fragment. C, patellar dislocation with a displaced osteochondral fragment. D, patellar tendon rupture. Or E, loose intra-articular body. And the most correct answer for this particular case is going to be a patellar dislocation with a displaced osteochondral fragment. In this particular case, we can see that there's marrow edema in the lower pole medial patellar facet and along the anterior peripheral margin of the lateral femoral condyle. We see this large detached and displaced chondral fragment associated with this large hemarthrosis, and the proper diagnosis is patellar dislocation with a displaced osteochondral fragment. Okay, question number 2. 23-year-old male weightlifter complains of chronic right shoulder pain. On physical examination, the position of comfort is noted to be with the arm in adduction and internal rotation. He demonstrates a decreased ability to perform external rotation. The axial images of the shoulder are shown below. So what is the most likely diagnosis? Again, this is a MR arthrogram with a T1 weighted image on top, a T2 weighted image on the bottom with fluid in the joint. Is this most likely a subscapularis tendon tear? Number 2, a type 2 tear. C, is this impingement with a partial thickness tear of the supraspinatus tendon? D, is this a posterior labral tear with paralabral cyst? Or E, is this a posterior Hagel lesion, humeral avulsion of the posterior band of the inferior glenohumeral ligament? And the most likely answer, or the most correct answer, is a posterior labral tear with a posterior labral cyst. Here we see a contrast or fluid completely undermining the posterior labrum, representing a tear of the posterior inferior glenoid labrum. Then we see this fluid signal collection extending along the posterior glenoid into the spinoglenoid notch posteriorly, representing a paralabral cyst.